the semi-conscious or awake patient, this is the adjunct to use, because although this might be irritating, but it is not irritating to the extent that the patient will actually vomit. And now, why we are so concerned about the reflex and unconscious patient? Aspiration, yes. So just imagine that a patient who's unconscious, no control, no muscle tone in the airway, and you trigger this reflex, and now hypopharynx is filled with gastric content. With the next breath, either if you are bagging the patient or if the patient actually initiated the breath, all or most of these secretions and gastric content will go down to the trachea. So in the airway management, aspiration is the nightmare. Aspiration is the thing that we like to prevent from happening. Okay? So anything that put the patient at risk of aspiration, we always will be worried about the patient airway, and we might sometimes intubate the patient to prevent potential aspiration. And we'll come to this down the road. Okay, so back to our scenario, the patient in the mall. You open the airway, patient is breathing but noisy breathing, you continue for 5 minutes, you get tired, somebody brought you the first aid kit, you found some of these in the adjuncts in the first aid kit, and then because the patient was fully unconscious, you decided to insert oropharyngeal. We'll talk about the insertion and the technique later on, but so with this adjunct in place, still there is noisy breathing and there is no much air movement that you can hear or feel. What is the next step? What is the next, let's say, upgrade? This is not enough. Patient is not breathing adequately, or the airway is not open adequately despite the presence of adjunct. So, what is the next step? Remember, you are in the mall, you cannot do endotracheal, right? Difficult. You can, I mean, EMS sometimes have to do it, but there has to be enough equipment and people who are trained. But for bystanders, it will be difficult.
Symmetrical or not?
So symmetrical, yeah. It is symmetrical, but the problem is we still have some component of obstruction on one side, there is noisy breathing, and the patient's effort is not enough.
Maybe it's PC.
Okay, then.
Maybe you change
the
it.
mall.
Use the back. Probably don't have.
So how, yeah, you might have the bag actually in the first aid kit, but why you want to use the bag?
To increase the pressure, positive pressure.
It is positive pressure, I agree, but you want to increase, why? Just, you're close to it, but give me more details. Any other thoughts in the group? Any other thoughts? So,
Full oxygenation or oxygen delivered to the
okay, okay. So we have, if the issue is inadequate effort, the patient is breathing slow, shallow breathing, and you think this is inadequate, then you might use a bag mask device. This is the mask bag, and here there is the bag. So if you see or read BMB bag mask valve apparatus or equipment, this is the one. Mask, valve, and the bag. So this will help increase the airway delivery or increase the airway movement, or sorry, the air movement in and out. It will help with the volume of the air exchange. So you might start bagging the patient in the presence of either OPA or MPA to increase the volume. Okay, if the patient effort is not enough, is not adequate, then you might use the bag mask. Okay. Now this can be used by one provider or bystander, and if there are two can use it to help optimize the effect from the bagging. However, now if we are not still achieving any adequate
Laryngeal mask.
LMA. So, what do you know about the LMA?
Supraglottic device.
It is supraglottic, yes, correct.
In the risk of
It is rapid than ventricular stimulation.
Okay, so yes,
Fine.
it can be inserted. It is not very time consuming because it does not require visualization. The ET tube insertion needs laryngoscopy, so you need to visualize actually the larynx and the vocal cord and then intubate the trachea. This does not need visualization, so it's not as time consuming as endotracheal tube, and it can be inserted what we call blindly, i.e. without visualization. So it can be inserted easily and it doesn't take much time. Now, what is the benefit over any other adjunct or device that we have seen so far?
Easy to use.
Easy to use.
Easy for suctioning.
This does not help with suctioning. No, this does not help with suctioning. The benefit of this, that this part, so laryngeal mask, this is the mask part, and it will sit just on top of the vocal cord. So if there is any obstruction or narrowing or anything that in the hypopharynx, this will bypass this and make sure that every breath that you deliver will actually go mostly 80%, 90% into the trachea. So instead of the air getting lost in the mouth cavity, sometimes some of it will go to the esophagus because of vigorous bagging. When you bag aggressively, some of this air will actually go into the esophagus and into the stomach. And if you see in real life, sometimes patients who have been bagged for a long time or long period, they will have abdominal distension or gastric distension because of this. So the benefit of this, it delivers most of the air into the trachea directly, and it will bypass any obstruction or narrowing from the oral cavity down to the larynx. If there is anything in the way, and you can insert this, if this overcome that narrowing or obstruction, partial obstruction, then yes, this will help with the ventilation and oxygenation of this patient. So, one second. Right. So, next step. Bag mask ventilation, plus minus. LMA. Remember, we can bag mask ventilate the patient with adjuncts on. If the issue is the effort, well and good. If you still have some obstruction, sometimes there will be very bad resistance to bagging. You're trying to bag the patient and there is resistance. If there is resistance, this means there is some obstruction. So if you need, you might actually put an LMA. If once you start bagging the patient, you're achieving good ventilation, there is no resistance, the chest rise is adequate, symmetrical, then this should be enough. If this is not enough and you figure from the scenario that this is more of obstruction, partial obstruction, LMA will help. Sometimes even with this, if you are trying to bag and with large volume you distend the stomach, it might be a better move to put an LMA because this will deliver the air to the trachea directly and will reduce the gastric distension. Okay, so LMA inserted. Now, obviously, if you use this, you have to take the oral airway. You can keep the nasopharyngeal airway, but the oropharyngeal airway has to be removed in order for the LMA to be inserted. So then, if everything, if all of these devices failed, or you have concern for
Local.
It is above supraglottic, supraglottic. It is supraglottic. So it does not pass through the vocal cord, so it does not prevent from aspiration 100%. Now, yes, covering the vocal cord will prevent the aspiration to some extent, but it's not something 100%. Okay? But in order for the aspiration to be prevented, we need ET. Are we clear until now? Any questions so far? We good? Okay. So ETT, either if everything fails or if there is risk of aspiration. If we have issues with adjuncts, we need more relief of the obstruction, or we need more air movement or volume. We either use diaphragm stimulation or the element. We use the ETT as last resort. So now we have a quick idea. I think we just touched about the airway algorithm, the emergency airway algorithm. So let's say that the patient, you decide that the patient arrived to the emergency department from the mall, and you found that he vomited actually during the transfer, and he is at risk of aspiration, and you decided to intubate the patient. In general, what other indications we have to intubate patients in emergency setting, not in OR setting, OR setting?
obstruction يكون مثلا.
Okay, so A, airway obstruction, or
Cyanosis.
we'll come to this now. Nothing. Any other thoughts? Something very important.
Loss of consciousness.
Consciousness, yes, what is the result of the loss of consciousness? We'll talk about it. So, but this is again obstruction. So, if we have the airway obstructed, this is one. The other thing that I was just mentioning is protection. Protection. Protection from what?
Aspiration.
From
Aspiration.
So, if any patient is at risk of aspiration, this is one indication for this patient. If there is airway obstruction that we could not overcome by other means, other devices, then yes, this is an indication. Now, we'll not go into details, but this can be sometimes something static, something dynamic, something that is in front of your eyes, something that you expect to happen in the next few hours, so you preempt and treat the patient. But in any way, the general headline is if there is airway obstruction and or risk of aspiration, if we need to protect, we need to intubate the patient. The other big category of intubation indications in emergency setting are
Respiratory failure. Respiratory failure.
respiratory failure,
Breathing problem.
like
Gasping. Decreased airway.
Coma.
Asthma.
Comatose.
Respiratory center depression.
okay,
Respiratory center depression.
sense of depression from the brainstem.
Comatose.
Comatose. So, the beauty about these indications is that they are general category, and under these you can have many examples. So, the B indication for intubation in emergency setting is inadequate oxygenation or ventilation. If this patient is hypoxic and we could not help this hypoxia with supplemental oxygen, even on 100%, even with bagging, even with LMA, we need to intubate the patient. If we did a blood gas and we know that the patient is having high CO2, or even by looking, the patient's effort is not enough to wash out CO2, like the asthmatic patient you mentioned. Problem with the asthmatic patient is ventilation. They oxygenate well, but they cannot exhale well, so they will start to accumulate CO2. So if we have inadequate oxygenation or ventilation that are not treated by other means or devices, remember in this category we have what?
Intubation.
about non-invasive ventilation? BiPAP. So sometimes we can solve this problem before going to intubation. We can try to use BiPAP or non-invasive ventilation in general. Might help. If BiPAP failed or non-invasive ventilation failed, then we go and intubate the patient. Finally, category C of indications. Anybody?
metabolic acidosis والكلوزز والريسبيراتوري acidosis والكلوز برضه acid base disturbance يعني
Why?
لأنه عشان يكون واحد يكون عنده مثلا acidosis
Sure, I know, but
يعمل وشات ضغط يعني
okay, they are washing out. Why should I wash out for them? Why should I breathe for them? Right? When we intubate the patient, remember, we put them in the ventilator, so we actually breathe for them. So those patients, if they failed, and they will be under this category, inadequate ventilation. So if they are supposed to wash out CO2 and they are not washing CO2 enough, then they fall under this category, inadequate ventilation or inadequate or high CO2, and then we treat for that reason. But not anyone. If the patient is compensating on his own, that is the best thing. You do not interfere. If the patient, however, is fatigued and starts to accumulate CO2, then this is the time you interfere.
When we decide to sedate the patient, maybe.
Okay, so good points. These loss of consciousness and altered mental status all fall under the A category because what happens with loss of consciousness, altered mental status, etc., is we start to lose the muscle tone, as we just mentioned, and then there will be some form of obstruction. And sometimes with the loss of consciousness, there will be loss of protective airway reflexes. Remember, we have protective reflexes, cuff reflex, gag reflex. If, because of this depressed level of consciousness, we have lost, or the patient has lost the reflexes, then this can qualify for intubation.
To deliver some medication to them. Maybe.
Intubate. Not an emergency setting.
section
No. Remember, intubation is the big deal, is a major issue. Patient, you will take the patient from patient who is spontaneously breathing to mechanically ventilated patient. So it's not an easy process. Weaning the patient from the ventilator is not an easy process. Keeping the patient on the ventilator is not an easy process. So for suctioning, you can do the suctioning without intubating the patient. If the patient is intubated for other reason, for a valid reason, you might suction the patient while intubated. Okay, category C.
Patient in coma.
Under A, because coma will cause loss of tone, loss of protective reflexes,
obesity ولا sleep apnea
not an emergency. Not an emergency.
Non-collapsing.
Why should I intubate for lung collapse? I would relieve the lung collapse. Manage to stable lung collapse.
Function.
Okay, so I would put chest tube, so I would relieve the lung collapse. Why should I intubate the patient? Right? I've solved the problem. So C is another big category, is anticipation of deterioration. i.e., that we expect this patient, although this patient currently does not meet any of these criteria, A or B, but we expect the patient to deteriorate in the next few hours. So we go ahead and intubate now rather than later.
What's the فرق بينه وبين protection?
Good. So I'll give you an example. So now I have a patient speaking to me, breathing normally, but this patient was just brought from a house fire. And this patient was trapped in a room, and he stayed there for some time. You look at the mouth, there's lots of soot. تعرفون شو السود؟ الدخان الأسود أو So lots of soot in his passages, nasal passage, oral cavity, etc. And he reported that he was there trapped in this very hot room for maybe half an hour, 45 minutes. damage, what we call inhalation and the damage to the airway vessels. And this, it is a matter of time before the airway swell and get obstructed. So those patients, despite that they are now speaking to me normally and they're totally fine, I will go ahead and intubate them now while it is easy and unobstructed airway, rather than waiting until they crash, have obstructed airway, and then it will be very difficult to intubate them with their airway. Okay? So this is sometimes what we do. There are other examples. Sometimes a patient with certain intoxication, you expect those patients to have very bad and difficult to control seizures. So we go ahead and intubate them now, because when they have prolonged seizure, obviously their airway obstructed, they can go hypoxic. So instead of waiting for this very prolonged status of crypticus to happen and then trying to intubate patient while in status, I intubate them now. And when they have status, I have a tube in the trachea so I can actually vacuum and maintain their oxygenation.
Doctor, you mean by this is that different stage, but all of them are the same for your
No, not stage. I say category.
category means that everyone they have ability of each other.
No. If the patient had any, this patient needs intubation in emergency setting. Remember, this is emergency setting. Our colleagues from anesthesia have different indications. Sometimes they will intubate the patient to facilitate surgical operation. Sometimes they will intubate to do something we call bronchial lavage. But this is not emergency indication. This is anesthesia indication. In the emergency department, in emergency medicine, we intubate only when it is strictly needed. When they are needed, any of these are big umbrellas, and of each one of them, there are many examples, tens, maybe hundreds, and anything, if you ask yourself, do I need to intubate this patient? Try to see, does he meet any of these? If he meets any of these, this patient is for intubation. Okay? So there is no, so you mean if he's having B, he's not priority, A is the priority.
Yeah.
No, they are equal. If the patient is having patent and no risk of aspiration, patent airway, no risk of aspiration, he's having protective reflexes, but his oxygenation is very low, and his CO2 is very high, and we have used non-invasive, and he did not respond, I would still intubate despite that the airway is patent and protected. And vice versa. I can have a patient with perfect oxygenation and ventilation, but with airway at risk of aspiration, and I will intubate. So these in general, no. So these are in general the indication for emergency intubation. Now when we decide to intubate a patient in the emergency department, we have something called algorithm. The algorithm helps us decide what way we will, or what approach we will take for this intubation. Now we decide this patient is for intubation. The question is how. We need to ask ourselves a few questions. Is this patient dead or dying? Give me an example. Patient who's dead or dying. Cardiac arrest is one very classic example for this situation. So a patient who is coming through the door with CPR ongoing, so this patient who falls under this category. If I decided to intubate this patient, which sometimes we do, sometimes we don't, it is not a hard rule, and we'll talk about this later, then if we need to intubate this patient for one reason or another, especially if while doing CPR, stomach content went all the way up and into the hypopharynx, and this is very common. Sometimes people will collapse or will have crashes or accidents just after a meal. And with the CPR, that's content will come to the oral cavity. So if we have the patient who dead or dying and he meets one of the criteria, then we use something called crash intubation or crash algorithm. crash course in emergency medicine, or a crash course in so and so subject. Crash course معناها short, very short, very condensed because you have no time. So this is a crash intubation because we don't have time to prepare the patient or to prepare medication, and we should just go ahead and intubate. So in crash algorithm, what we mean by crash is that we would try to intubate without the use of the medication. Without use of medication. What medication we mean?
Succinylcholine.
Yeah. Succinylcholine example of what category of medication?
Muscle
I
None.
disagree.
Non
Non-competitive?
non-depolarizing muscle
Non-depolarizing.
relaxant.
Okay. So I disagree with the name muscle relaxants because it is deceiving. The better name is paralytic. This is what actually these medications do. They paralyze the patient. They paralyze the patient. So you have to be extremely cautious before paralyzing the patient because you will take the responsibility of this patient's life, بعد الله سبحانه وتعالى. You will give the medication while the patient is breathing on his own. You will paralyze the patient, and if you fail to intubate and maintain the oxygenation and ventilation of this patient, then that's on you. So it's huge responsibility and huge risk. So paralytics are very big deal, and you will notice because paralytics are big deal, there are different algorithms. We use different algorithms than our anesthesia colleagues use. So in general, if we have patient dead or dying, for example, during CPR, when we try to intubate, we try to intubate without the use of medication. We don't, in most of cases, we do not use the medication. The reason is, with the hypoperfusion from the cardiac arrest, the muscle tone has been lost. The perfusion to the brain is very low and inadequate, and as a result, the muscle tone in the upper neck, hypopharynx, and the airway is lost. So the paralytic has very little to add, if any. We use the paralytic usually with patients with tone who are conscious to paralyze their muscles and to optimize the intubation. But those patients, because of their condition, they are already flat, they have low tone or atonia, no tone at all. So there is usually no need to give them paralytics. So the first attempt at intubation or laryngoscopy will be done without. Now, in case you have patients who still have tone for some reason or another, and this sometimes happens, you can administer one dose. It's actually double the usual dose of paralytics to those patients, trying to intubate them. Okay? So crash means no paralytics. واضح؟ Are we clear? Approved. Yeah.
What يعني this special case, but what if he came out of his poison?
Like
Rat poison.
what is special about rat poison?
Lungs will arrest. Lungs will full arrest.
I don't know what type of rat poison that you speak about, but how does it how does it?
give psychoactive, yes?
If you think the rat poison is
Yeah.
actually a paralytic.
Yeah.
Okay. So this patient depends in what state he or she will come to you. If the patient is having tone, he will have to be paralytic. If the patient has lost the tone, you don't need to do it paralytic. If the patient is dead or dying. Okay? If he's in this category. If he is not dead or dying, there is a pulse, there are vital signs, then we deal with it differently. Okay? So if yes, this is crash. If no, we ask the next question. Does it look difficult airway? Did you hear about the difficult airway from our colleagues in anesthesia? Okay, so difficulty in airway can be divided or categorized. We have some physiologic difficulties, some anatomic difficulties, and we're not going into details because this from the look of the patient, I see that this will be a very different airway. There is tumor, huge growth, the airway is disrupted maybe. I cannot actually identify anything from the airway structures. Or the patient is having maxillofacial trauma, and all the structures are lost, structural integrity, etc. If I have any reason to think that this is going to be difficult airway, then we have difficult airway either or difficult ventilation. Okay. What is the core of difficult airway? Why is it different? What do we do differently in difficult airway?
Maybe tracheostomy. Yeah.
Okay, we'll come to the surgical airway. Surgical airway is there, but not here.
ممكن كان fracture عشان كده difficult airway.
Yeah, we decided that this patient, from the look, difficult. So what do we do differently?
We will not start with nasopharyngeal or oropharyngeal from the start. We have other things.
No, you can actually try. They can sometimes help.
We got new organ doctor trachea.
No, not necessarily. Not necessarily. Remember, difficulty can be sometimes physiological. Cannot be sometimes solved by surgical airway. The anatomical difficulty can be solved by surgical airway. We'll come to this, don't worry. But sometimes difficulty is physiological. So keep this in mind. So in general, when we have difficult airway, let me just ask you, did our colleagues from anesthesia tell you about the normal sequence? How do they actually anesthetize patients or induce patients in the OR? What are the steps that they use?
Start with the IV.
Okay, IV and then?
Intubation and anesthetics.
كده يا رب.
ايش الاندكشن جازز اول شيء نبدا في الاندكشن انستيزيا في
طيب,
الماسك بعدين
induction gas or IV doesn't matter. But what's important is the sequence. What is the order of steps?
Hypnotics. We will go for that.
Excellent. One essential step in difficult airway is called for that. Thank you. And if you have special equipment or tray or trolley for difficult airway which has advanced equipment, you should get this trolley. Thank you. What else?
Further?
Injury or trauma or non-trauma. No, difficult airway. Let's talk about the normal sequence. Sorry, I suppose that you know this from your anesthesia rotation. So our colleagues from anesthesia, they will have the patient at the table at the OR. First thing, they will push sedative medication. Okay? And then they will try to bag mask ventilate the patient. If the bag mask ventilation is successful and adequate, they will come here at this point and they will push paralytic. And then once the paralytic takes effect, they will intubate the patient. This is what we call normal sequence. What is the rationale behind this? Dish?
To overcome the gag reflex.
No, I'm talking about here our focus is the steps. Why they are doing it in this order.
عشان يكون easy integration.
عشان المريض ما يحس
Sure. But لكن ليش ما في مثلا sedation paralytic سوداء مع بعض؟ Why the sedation bag mask then paralytic?
عشان نتأكد إذا سديت أو ما كان سديت اللي سوينا لنا باراليسيس ممكن يكون صاحي ما
Will be easier? Good thought, like this is not the correct answer. This is one of the things, one of the malpractice issues for anesthesia. If the patient for one, one level or one time or one moment during the operation was awake while paralyzed or awake in general, this is a huge malpractice for our colleagues in anesthesia. So we have any patient who is undergoing surgery, the worst thing in life that you can experience is being alive, hearing everything, feeling everything, including painful stimuli, surgery, cutting, etc., and then unable to do anything because you are paralyzed. So if this happens at any time during operation, this is a base for malpractice. And this is one of the important things that we focus on, that once the patient is intubated successfully, we will immediately initiate sedation, because having a tube in the throat is not a pleasant sensation. And for other reasons, for multitude of reasons, we use short-acting paralytics, sequence. So, remember that we said aspiration is the enemy of the airway.
Yes.
What are the instructions before OR?
MBO.
MBO since midnight, maybe since 9 p.m. Why? To ensure that the stomach is empty next morning. So, we said that back mask ventilation has the risk of distending the stomach. Right? So, if the patient in the normal sequence, anesthesia patient, planned elective surgery, there is no risk from back mask ventilating the patient because the stomach is empty. Even if it was distended, the worst that will happen is the patient will burn. And burn. Yes. So we'll get the air out. There's no aspiration, there's no risk. So our police from anesthesia, for safety, and because this patient is a prepared patient, they will initially give some sedation. And they will try to bag the patient. If they feel that with sedation, they are able to bag the patient adequately, maintain oxygenation, then they will take the step to give paralytics. This is very dangerous deal, given paralysis, because the patient will go from spontaneously breathing to paralyzed, and you have to immediately take over for oxygenation ventilation. So, as risk reduction and for safety, they want to make sure they can bag the patient. So, in case, after giving the paralytics, they could not intubate the patient, they know that they can wait for the paralytics, which is short-acting, to wear off while maintaining the oxygenation and ventilation by bagging the patient. So they have a way back. They have a rescue back. They have options. Absolutely. This is all I would have.
That's my
Welcome. So, police from anesthesia would like to be very safe. This is a planned procedure. There's no rush. So, if this patient turned to be difficult after giving the paralytics, they will continue bagging the patient. They could not intubate for a reason or another. They could not intubate the patient. Okay, they will continue to bag the patient, and they are sure they can bag the patient satisfactorily because they have tried. They have given this trial of back mask ventilation, and they were happy they could ventilate and oxygenate the patient. So if something happens after paralysis, they would just wait for the paralysis to wear off, and then they would, during that time they will continue bagging the patient. When the patients start to wake up, they will wake up the patient, send them back to the ward, reschedule the surgery in a later date. Voila. So this is when it is planned with empty stomach. This is the normal sequence. When we have difficult airway, we have something very similar to do. What we will do is something called awake look. Awake look. What does it mean, awake look? Means that I will give this patient lower dose of sedation, not full dose of sedation. Okay? So I'll give the patient what we call procedural sedation level of sedation and local anesthesia. So sometimes this is difficult because the patient will be still breathing, so vocal cords will open and close all the time. So the patient is still actually breathing on his own. If I could not see anything, again, I did not paralyze the patient is still breathing, I can take my laryngoscope out, ask for somebody more senior, ask for different equipment, but I did not give the patient paralysis. I did not paralyze the patient. لأنه خطوة اللا عودة هذه هي paralytics. If you give paralytics, then you have to breathe for the patient. So this is the awake look. Awake look is giving the patient sedation but no paralytic, while I ensure that I have a good view and I can intubate this patient. If I can, well and good, I have two options, either immediately intubate the trachea, or go back, push the paralytics, and then intubate the patient. If I could not have a good look, I did not see the vocal cords, it was very difficult to see, then again, I would just wait for the sedation to wear off while getting different equipment or somebody who is more experienced. واضحة? Are we clear on this? Okay. So, if this airway does not look to be difficult, what is the so patient is not dead or dying, does not look to be difficult, regular patient, standard patient. If no, then this is what we call rapid sequence intubation. So the standard, the default is rapid sequence, unless the patient is having features of difficult airway, or the patient is dead or dying, or RSI. Right. So, rapid sequence, anyone knows? سمعت فيه؟ لا. هذيك right hand stimulation. Anyone? واضح no. كل الكلام الفاضي هذا ما حد فاهم منه حاجة. What is rapid sequence?
اللي يكون مثلا فيها البريبريشن قبل الريوكسجينيشن زي كذا.
لا ما له علاقة بالإكويبمنت. طيب هذا قلنا اللي يسمونه الانستيزيا ايش سميناه؟ نورمال سيكونس. ايش معنى رابد سيكونس؟ رابد سيكونس معناه اني انا ابدا من هنا تايم زيرو patient fully conscious, spontaneously breathing, but having one indication for intubation. I will immediately, هنا خلينا نقول normal. Here I will give sedation and paralysis at the same time.
Intubation.
And no bag mask ventilation. And then here. So here they will give sedation, bag mask, then paralytic, then intubate. Rapid sequence, I will join the paralytic with the sedation. I will cancel the bag mask ventilation, and then I will go for intubation. And that's why it is called rapid sequence. Okay, so why is this the default for emergency intubation?
عشان التعليم.
No.
لا لأن الستومك فل بتكون.
Yes. So because the stomach is full, I will not bag the patient. This is one part of it. So one part of it, because the patient can be full stomach, I cannot give the patient bag mask ventilation when the patient is unconscious or sedated. قبل ما عندي مشكلة. When the patient semi-conscious. بس بعد الميديكيشن حقتي ما أقدر أسوي له bag mask ventilation. Tone is lost, patient is unconscious, no protective reflexes. I can actually induce vomiting and aspiration. So no bag mask ventilation. So that is one part. The other part. Anyone? anesthesia operatic airway. Or if they could not intubate the patient. أيوة. وريسكيدول. طيب. Do we have this option in the emergency?
Yeah.
There is no going back in the emergency department. If somebody needs to be intubated because of any of these emergency indications, his breathing is not good enough to go back to. هذا قبل الانتوبيشن وقبل السيديشن he was breathing normally. His breathing was adequate. But my patient is not normal. لا صح نقول baseline. So his baseline was inadequate. So I decided to intubate the patient because his baseline is inadequate. So there is no point of going back. You go, oh, well, if I could not intubate this patient, I wait for the medication to wear off, and then he will go back to the respiratory shallow rapid breathing, the respiratory distress that he was in. Okay? So for these two reasons, this is the standard approach for emergency intubation. Rapid sequence intubation, some people call it induction. There is preparation part here, and if you read about it, RSI has 7 P's approach. مرة ثانية شو الأول؟ لا لا فرنسا هذا طيب أوكي فرنسا. So no 7 P's ده غير حقيقة الكومبارتمنت no 7 P's there is preparation of the equipment, there is pre-oxygenation of the patient, and then you have to pre-medicate the patient sometimes, you have to position the patient, you have to visualize, and then intubate, and then paralyze and induction, visualize, fix the tube, and then post-intubation sedation. You can read the 7 P's, it's not a big deal, but so you have steps, but the core or the difference, the main difference is that there is no bag mask ventilation and there is no going back. Once you start outside, you have actually to intubate the patient. Any questions so far? أخذ الأرسال. So, عندنا crash لمن؟
Did or
die.
Difficult.
الأواكلة.
Awake. Okay. Otherwise, standard patient or regular patient?
RSI.
So, now, last 2 words. Then we will finish the introduction. أنا أنصحكم تتكلموا من دكتور السكر تقولوا إنه محاضرة منفصلة وركشوب منفصلة. لأنه موضوع حق الأيرواي موضوع كبير. طيب last segment, last piece of the algorithm is at any point going to be crash, going to be awake, going to be RSI. At any point, if you cannot intubate and cannot oxygenate, this is a failed airway. Cannot intubate plus cannot oxygenate, هذه equals failed. At any time during any part of the airway management. If you did not put the tube in, still yet, not yet, and also you cannot maintain the oxygenation with bag mask ventilation adjuncts or LMA, then this is a failed airway. Failed airway, what is the solution?
Surgical.
And an emergency setting, because time? No, it's not tracheostomy. Yes. Why? Because it can be identified on an anatomical basis and it is faster. Tracheostomy is time consuming and needs any surgeon who is in this position يدعو الله إنه ما يجي له emergency tracheostomy. Why? Because the patient will be hypoxic for minutes and this is time consuming. So you need a patient to at least oxygenate ولا أي وسيلة ثانية while doing the tracheostomy. But cracktherapy, no, is very quick, very brief. You identify the brain, you cut it once, and you put the tube in, and you restore the oxygenation, which is the priority. Tracheostomy, again, you have to take the muscles off, and you have to cut the trachea, and then you have to, so it is time consuming. So the emergency surgical airway is always cracktherapy. You might, if you did not use LMA before, you might, before jumping and doing cracktherapy, you might try to help oxygenate the patient using LMA. But if the patient is or cannot be oxygenated well, even with LMA, then right. واضح؟ Any questions؟ يعني إذا أسألكم الدكتور ستنكا قال لكم كراش ايرواي ولا تعرفون؟
إن شاء الله.
5 minute stretch and then we'll come back to the